In the previous lectures, we discussed the basics of cholinergic pharmacology. First, we looked at the functions of the parasympathetic nervous system and the types of effects it produces in the body when it becomes active. Then we understood how these effects occur, mainly through the release of acetylcholine, which acts on two types of receptors, muscarinic and nicotinic receptors. We also discussed where these receptors are located and how they are distributed in different organs. Now, building on that background, we will move forward to study how drugs interact with these receptors. In this section, we will mainly focus on direct-acting muscarinic agonists, which stimulate muscarinic receptors and mimic the actions of acetylcholine. Before moving ahead, let's briefly review the effects of the parasympathetic nervous system, often called the rest and digest system. When activated, it produces several characteristic effects in different organs. In the eye, it causes miosis, pupil constriction. In the heart, it slows the heart rate. In the lungs, it leads to bronchoconstriction and increased respiratory secretions. In the gastrointestinal tract, it increases digestive secretions and enhances smooth muscle contractions. It also stimulates glandular secretions such as salivation and lacrimation, and in the urinary system, it causes detrusor contraction with sphincter relaxation, facilitating urination. Overall, the parasympathetic system prepares the body for rest, digestion, secretion, and energy conservation. So even before discussing any specific drug from these parasympathetic responses, we can already predict what muscarinic agonist drugs will do in the body. For example, they can cause bronchoconstriction and increased respiratory secretions, which may worsen breathing in patients with asthma or COPD. On the other hand, in the eye, they produce miosis, an effect that can be therapeutically useful in glaucoma. In the heart, these drugs slows the heart rate. Therefore, when muscarinic agonist drugs stimulate muscarinic receptors, they essentially mimic or exaggerate these parasympathetic effects. Now let's begin discussing muscarinic agonist drugs. Broadly, these drugs can be divided into two main types: direct-acting and indirect-acting muscarinic agonists. First, we have the direct-acting drugs. As the name suggests, these drugs directly bind to muscarinic receptors and activate them, producing effects similar to those of acetylcholine. On the other hand, we have the indirect-acting drugs. These drugs do not bind to muscarinic receptors directly. Instead, they act by inhibiting the enzyme acetylcholinesterase, which is responsible for breaking down acetylcholine. When this enzyme is inhibited, acetylcholine is not hydrolyzed quickly and therefore accumulates in the synapse. As a result, acetylcholine can remain in contact with the receptors for a longer period of time. Direct-acting muscarinic agonists include acetylcholine, methacholine, Carbachol, Bethanechol, Pilocarpine, and Cevimeline. Indirect-acting drugs are further divided into reversible and irreversible acetylcholinesterase inhibitors. As the name suggests, reversible inhibitors temporarily block acetylcholinesterase, so acetylcholine increases for some time, but eventually the enzyme becomes active again. Whereas irreversible inhibitors permanently inactivate acetylcholinesterase, so acetylcholine accumulates continuously and produces prolonged cholinergic effects. So reversible inhibitors include edrophonium, neostigmine, physostigmine, pyridostigmine, donepezil, rivastigmine, and galantamine. Irreversible inhibitors include organophosphates such as ecothiopate, isofluorophate, parathion, malathion, sarin. Another important concept is that muscarinic activation is generally non-specific. Most muscarinic agonists stimulate multiple receptor subtypes, M1, M2, and M3 at the same time. Because of this, when these drugs are used for one therapeutic purpose, such as increasing gastrointestinal motility in ileus or severe constipation, they may simultaneously produce other effects like bradycardia, miosis, or increased glandular secretions, which appear as side effects. For this reason, muscarinic agonists are not widely used in clinical practice and are usually reserved for specific indications. To reduce systemic side effects, they are often administered locally rather than systemically, such as topically in the eye or by inhalation in the respiratory tract. So the drug mainly acts at the target site while minimizing effects in the rest of the body. Now let us briefly discuss these drugs one by one. First start with acetylcholine. As we can see in the table, acetylcholine is rapidly hydrolyzed by acetylcholinesterase, which means it is broken down very quickly in the body and therefore has an extremely short duration of action. In addition, it can stimulate both muscarinic and nicotinic receptors, so its effects are not selective. Because of this rapid breakdown and non-selective action, acetylcholine is rarely used systemically as a drug. However, it is sometimes used topically in ophthalmology, mainly to produce miosis during ophthalmic surgery, where it is usually instilled into the eye as about a 1% solution. Next is methacholine. In our previous lecture on cholinergic pharmacology, we discussed that methacholine is produced by adding a methyl group to the acetylcholine molecule. And because of this modification, methacholine becomes resistant not only to true cholinesterases but also to pseudocholinesterases. So compared with acetylcholine, methacholine is more resistant to hydrolysis by acetylcholinesterase, so its effects last longer. It mainly produces muscarinic effects, particularly in the respiratory tract, where it causes bronchoconstriction and increases the secretions. Look, there is really no clinical condition in which we intentionally want bronchoconstriction and increased tracheobronchial secretions in a patient, because these effects generally make breathing more difficult and can worsen respiratory problems. However, there is one special situation in clinical practice where we deliberately induce bronchoconstriction, not for treatment purpose, but for diagnostic purposes. So methacholine can be used to intentionally provoke bronchoconstriction in the methacholine challenge test, which helps in diagnosing bronchial hyperreactivity in patients who do not have clinically apparent asthma. So in this case, the goal is not to produce a therapeutic effect, but rather to use the body's exaggerated response to help confirm the diagnosis. In this test, methacholine is administered by inhalation. The drug is usually available as a powder, which is first diluted with normal saline, and then it is given through a nebulizer. After inhalation, methacholine stimulates muscarinic receptors in the airways and causes bronchoconstriction along with increased tracheobronchial secretions. Now, this effect can occur to some extent in all individuals, but the important point is that patients with asthma or bronchial hyperreactivity respond much more strongly. In these patients, methacholine produces marked bronchoconstriction, which leads to a significant reduction in lung function parameters such as vital capacity or FEV1. During the test, lung function is usually measured before and after inhalation of methacholine. And if there is a significant fall in FEV1, it suggests the presence of bronchial hyperreactivity, which supports the diagnosis of asthma. One important thing to remember is that the response to methacholine can be more exaggerated or prolonged in patients who are taking beta-adrenergic receptor blockers, because these drugs prevent bronchodilation. There are also some important contraindications for performing this test. It should not be performed in patients with severe airflow limitation, recent myocardial infarction, recent stroke, uncontrolled hypertension, or during pregnancy. In addition, because severe bronchospasm can occasionally occur during the test, it is essential that emergency resuscitation equipment, oxygen, and bronchodilator medications such as inhaled beta-2 adrenergic agonists are readily available while performing the test. Now let us move to Carbachol. According to the table, Carbachol is not hydrolyzed by acetylcholinesterase, which means it has a relatively long duration of action. However, it can stimulate both muscarinic and nicotinic receptors strongly, which limits its systemic use because it may produce widespread effects. Therefore, Carbachol is mainly used locally in ophthalmology, particularly for the treatment of glaucoma and for producing miosis during eye surgery. In clinical practice, it is usually administered as 0.01% to 3% ophthalmic solution. Next, we have Bethanechol, which is an important clinically used drug. Bethanechol is resistant to hydrolysis by acetylcholinesterase, and unlike Carbachol, it does not have significant nicotinic activity, meaning it acts mainly on muscarinic receptors. Because of this selective action, Bethanechol primarily affects the gastrointestinal tract and urinary bladder. If we look at the urinary tract, Bethanechol increases the contraction of the detrusor muscle of the bladder, which helps in proper emptying of the bladder. Because of this effect, Bethanechol is useful in conditions where the bladder is unable to contract adequately, leading to urinary retention. However, it is important to remember that this drug is used only when there is no mechanical or organic obstruction in the urinary tract. A mechanical or organic obstruction means that there is a physical blockage in the urinary pathway, such as an enlarged prostate, a stone, a tumor, or any structural narrowing of the urethra that prevents urine from flowing out of the bladder. Now imagine if we give Bethanechol in such a situation. Since Bethanechol stimulates the detrusor muscle of the bladder to contract strongly, the bladder will try to push urine out. But because a physical blockage is present, the urine still cannot pass. This can lead to increased pressure inside the bladder, causing pain, worsening urinary retention, and even potential damage to the urinary tract. Therefore, Bethanechol should only be used when the problem is due to poor bladder contraction, not due to a structural blockage. In clinical practice, this is usually evaluated by proper history, physical examination, and imaging studies such as ultrasound of the abdomen or bladder. Clinically, Bethanechol may be used in situations such as post-operative urinary retention, diabetic autonomic neuropathy, and certain cases of chronic hypotonic, myogenic, or neurogenic bladder. In such patients, Bethanechol can help restore bladder emptying and may even avoid the need for catheterization. When the drug is used chronically, the usual oral dose is around 10 to 50 milligrams taken 3 to 4 times a day. And it is generally recommended to take the drug on an empty stomach. That is, about 1 hour before meals or 2 hours after meals in order to reduce side effects like nausea and vomiting. Another naturally occurring muscarinic agonist is pilocarpine. Pilocarpine is not hydrolyzed by acetylcholinesterase and acts mainly on muscarinic receptors, especially those present in exocrine glands and the eye. It is commonly used to treat xerostomia, that is, dry mouth, that occurs after head and neck radiation therapy, or in patients with Sjogren syndrome, an autoimmune disease that mainly affects women and damages the salivary and lacrimal glands, leading to reduced saliva and tear production. By stimulating muscarinic receptors in the salivary glands, pilocarpine increases salivary secretion, which helps improve swallowing, oral lubrication, and overall hydration of the oral cavity. However, because pilocarpine stimulates the parasympathetic system, it can cause cholinergic side effects, the most common being excessive sweating. The usual oral dose is 5 to 10 milligrams 3 times daily, and the dose should be reduced in patients with hepatic impairment because the drug is metabolized in the liver. In addition to systemic use, pilocarpine is also used topically in ophthalmology to treat glaucoma and to produce miosis. It is administered as an eye drop solution ranging from 0.5% to 6%. Another drug used for the treatment of xerostomia is Cevimeline, which is also a muscarinic receptor agonist but has a more selective action. It preferentially stimulates M1 and M3 muscarinic receptors present on the epithelial cells of lacrimal and salivary glands. Because of this relative selectivity, Cevimeline produces a strong and long-lasting stimulation of saliva secretion while causing fewer systemic cholinergic side effects compared with pilocarpine. The usual dose of Cevimeline is 30 mg 3 times daily. When we talk about the contraindications, precautions, and adverse effects of muscarinic agonists, most of them are actually predictable, as these drugs mimic the parasympathetic nervous system. So wherever parasympathetic receptors are present, the drug can produce its effects. Because of this, there are several important contraindications. For example, in patients with asthma or COPD. Similarly, these drugs should not be used in patients with urinary tract obstruction or gastrointestinal obstruction. They are also contraindicated in acid peptic disease, since stimulation of muscarinic receptors increases gastric acid secretion, which can worsen ulcers. As muscarinic agonists can produce bradycardia and hypotension, so they should be avoided in patients who already have slow heart rate or low blood pressure. In patients with hyperthyroidism, these drugs may even precipitate atrial fibrillation because the heart becomes more sensitive to autonomic stimulation. Now, regarding the adverse effects, again, these reflect excessive parasympathetic activity. Patients commonly experience diaphoresis, that is, excessive sweating, which is one of the most frequent complaints. Gastrointestinal effects are also common, including diarrhea, abdominal cramps, nausea, and vomiting. Patients may also feel a sense of tightness in the urinary bladder due to increased detrusor muscle contraction. In the eyes, muscarinic stimulation can lead to difficulty with visual accommodation, making it harder to focus on distant objects. Cardiovascular effects such as hypotension may also occur, and this can reduce coronary blood flow, especially in patients who already have compromised cardiac circulation. However, it is important to note that many of these systemic contraindications and adverse effects are less significant when muscarinic agonists are used topically in the eye, such as in the treatment of glaucoma. Because the drug is applied locally, systemic absorption is limited, so the overall systemic effects are usually minimal.